Hello everyone, this is Amy Dimmer. I'm going to talk to you today about my quality improvement project, reforming patient care delivery through a standardized discharge process. Hospitalization is a stressful time for patients and families. However, the transition from hospital to home is just as confusing and is a susceptible time for patients to be negatively impacted by an insufficient discharge process and inadequate follow-up care. The discharge process is instrumental in informing patients of their disease process and necessary self-care practices to do once they're discharged home. There are multiple issues that contribute to ineffective care transitions, including poor communication between inpatient and outpatient clinicians, medication changes during the hospitalization, and inadequate patient understanding of their diagnosis, their medications, and their follow-up needs. At this facility, the discharge process lacked sufficient information, was not uniform, and it potentially created additional strain on the patients being discharged home during this transition time. So incorporating a standardized discharge process using Project Reengineered Discharge, or Project RED, to include the discharge education standardized, preset appointments, and post-discharge phone calls was an intent to improve the patient's access to care. This facility had a disjointed manner in which they completed the discharge process. In many conversations with the stakeholders, looking at patient appointments, patient satisfaction, post-discharge phone calls, all three of those were well below what the stakeholders' desired values were. So in looking at the issues that the facility had, I decided to try and implement components of Project RED to try and improve their access to care by utilizing the preset appointments, the standardized discharge information, discharge phone calls that were done after they were discharged home. To do this, we need to do a system change to prevent these poor outcomes. A standardized discharge process utilizing components of Project RED were instituted. Now, Project RED, it's a 12-component guideline or a toolkit. It's all online. You can utilize these components. It kind of gives you a guideline of how to complete these at your facility. And what they are intended to do is to impact patient care, especially the post-discharge access to care, in an effort to prevent complications from illnesses. So for this facility, we chose 4 components. Those were the prepared checklist for nursing, the preset appointments, a unified reference resource, and post-discharge phone calls. The facility is a small community-sized military hospital, and the project participants that were included were adult patients who had a chronic health condition that were admitted to the 32-bed medical surgical floor with a planned discharge home. So excluded were anybody who did not have a chronic condition, anybody who was a child, and any of those patients who, even if they had a chronic conditions, instead of going home, they were going to an extended care facility or rehab. Those patients were excluded. The FADE model of quality improvement was used to implement the procedures to improve the patient's access to care at this facility. Now, FADE stands for Focus, Analyze, Develop, Execute, and Evaluate. It's a very cyclic event. You go through, you kind of identify what the facility problem was, you analyze the current process. So how is the facility currently doing it? Again, during the analyze phase, I noted that they were not using any specific discharge form that was able to be given to the patient so they could go home and refer to that later. There were not enough staff utilized to preset these appointments. There were not enough staff to do the callbacks. And additionally, the EMR, the electronic medical record, was not being utilized properly. It had a system already built in that you could have information migrate from one form to another form, and that discharge form then could be given to the patient so they could refer to it. So during that analyze phase, I noted that none of these processes were being utilized. So then the develop, I had to figure out how to develop the processes to to get this. So I had to engage leadership to get additional staff, to provide manpower for the preset appointments, provide manpower for the callbacks. Had to work with the EMR technician to get the information that I needed to migrate into the discharge form, go through and instruct the staff on how to input the information so then it would migrate appropriately. And then the execute and evaluate is when we decided to go live, and this was the go live with the new form and making sure the staff was utilizing it properly and evaluating how they were doing it. So those were the methods and procedures. And part of that did include the identifying of a specific resource for the educational material, because prior to the project there was not a central location that everybody used. Lexicomp, for example, they would just use whatever the nurse decided that they want to use. And then there was also not a post-discharge script, so if anybody was completing a post-discharge phone call, there was not a specific guideline. Ask the patient this, inquire about that. There was none of that that had taken place prior. The data collection included chart audits of the patient's discharge home and the preset appointments to see if that area was completed, and to see how the nurses and the physicians were doing with the new documentation. I looked at that twice a week. To get information on the discharge phone calls, I looked at the discharge manager's files, and I also was able to complete some of the phone calls myself. I reviewed the TRICARE Inpatient Satisfaction Survey, or TRIS. I reviewed those for the last quarter of 2016 and then the first quarter of 2017 to try and do a comparison between prior to the project and then after the project. Once I obtained all this information, I was entered into SPSS. I identified those percentages of improvement, it noted the trends in the data, and then it also enabled the comparison of the pre and post project data. A total of 68 patients were involved in the project. The preset appointments improved, the post-discharge callback percentages improved, chart compliance improved, and TRIS scores improved. The chart compliance was a little bit difficult to ascertain the improvement because, again, prior to implementing the project, there was no chart audits that could be done on this data because the form wasn't even being used. It hadn't even existed. So I had to go from midpoint, and at midpoint we had 64%. What I ended up doing at this point in time was to contact some of the nurse leadership and the physician leadership and chose providers, either nurses or physicians, who were doing the process correctly, acted as then change champions, and these individuals given additional class, and it finally did an improvement of 91.5% at the project end. So using a change champion, getting those people who were in love with the project, thought it was a good idea, and they were willing to kind of go above and beyond and give that additional information to their peers, was essentially the best thing. So again, there was improvements across the board in the preset appointments, the post-discharge phone calls, the use of the discharge form, and then the TRIS scores. So then trying to equate how the TRIS scores went with a standard civilian hospital, again, because this was a military hospital, I did compare the TRIS scores to the Hospital Consumer Assessment of Healthcare Providers and Systems. The reason that is important is HCAHPS is the standardized survey instrument that is used for measuring a patient's perspective on hospital care. So it enables you to have comparable data on what a patient's perspective is about your hospital, comparing it to a hospital of a like size or a like location. So, hey, is hospital down the street doing better than we are? Since military doesn't really participate in that, we have the TRIS scores. I was still able to equate some of those values by utilizing HCAHPS. And the other reason that it was important is because HCAHPS is kind of related to the Centers for Medicaid and Medicare Services, and they have to rely on some of that input. So military hospitals still respond to those guidelines, even though we're not governed the same way as, say, a civilian hospital is. We still kind of go with them. So that's why I use that. In this particular facility, the HCAHPS benchmark was 87. So comparing our hospital to a like hospital, the benchmark was 87% for patient satisfaction. At the end of the project, our TRIS scores were 91%. So we again surpassed even the HCAHPS standards. Again, this is just a brief chart that shows just the beginning of the process, the midpoint process, and the final process of how things improved. So the preset appointments did increase thanks to the additional staff trained to make those appointments, and required that those discharge appointments be entered into the EMR. The post-discharge callbacks improved because we had those additional staff trained. The uniform education material was used fairly consistent. That way all of the patients who had congestive heart failure, for example, were getting the same information, except for their medications that were different patient by patient. They were all getting the same information on what their diagnosis is. The patient satisfaction scores increased. The post-discharge callbacks stated that many patients were satisfied with the new process, and they expressed that they felt better prepared to take care of themselves. This quality improvement project improved the care of patients with chronic disease processes at a small facility. Patients now have the educational material necessary to care for themselves and the added benefit of a post-discharge phone call to check on their well-being. The project took minimal additional staff and time to complete. The project findings indicate that a standardized process improves patient care, and utilizing Project RED as a guide, the discharge care can be improved at other facilities with less than optimal processes. Previous research on Project RED has identified that a standardized discharge process positively impacts patient care, patient access to care, and even hospital readmission rates. Future research should look at the number of patients who have actually made it to their follow-up appointments that were preset prior to the exacerbation of their disease, and linking that as a result of the improved information and the improved access to care that they received through this discharge process to see if it impacts even those rates. Thank you. Have a great day.